Okay, so the purpose of the molecular tumor board is to help patients. That is our focus. And Jim has done an amazing job in making this trial happen for patients across the country. And with now hundreds of patients that have been consented. And this is really a great team effort. And I do want to mention that in addition to the patients that are from almost every state, and Jim mentioned that the molecular tumor board members are from all over the country too, and we come together, but some of the institutions involved are really the top institutions and include Dana-Farber, MD Anderson, UCSD, Sarah Cannon, John Hopkins, Foundation Medicine. So really some of the best institutions in the country have participants. We need somebody from Memorial Sloan Kettering. But anyway, so we are going to present a case, and if people have questions, please feel free to interrupt us, but we also will have a session at the end of the presentation where you can all ask questions. And we're going to have Dr. Vicky Thapa from Dana-Farber, who's going to present the medical history and clinical features, and he's a GU specialist. This patient has a GU tumor. I'm going to go over the blood and tissue-based genomic analysis. Dr. Sabaya, who's one of the top clinical trialists in the world, will discuss the clinical trials that may be available. Dr. Nakunjam will discuss the dosing of novel combinations, which I alluded to during my previous talk, and a lot of the data that informed our dosing actually was curated and published by her. And then Hedel will talk about the germline analysis. So, Vicky, if you want to start, go ahead.
Yeah. Thank you, Dr. Kozrak and Jim for to participate in the MTB. This is a snapshot of the case. 60-year-old gentleman with a urethral adenocarcinoma. He had neoadjuvant gemcitabine and cisplatin, and followed by resection of the tumor. After that, no recurrence of the disease, and patient is on surveillance. I'll briefly go through the medical history. Initially, in March 2024, patient had voiding symptoms where he is not able to pee. So he was found to have mass in the urethra with the cystoscopy, and biopsy and some resection of the tumor was done, and the pathologist showed invasive carcinoma, extensive glandular differentiation. Subsequently, restaging scan with PET CT from May 2024 showed urethral carcinoma with concern for right external lymph node lymphadenopathy, so concern for locally advanced disease. The MRI prior to that showed some shrinkage of the tumor, and patient was started on neoadjuvant chemotherapy, gemcitabine and cisplatin, which is usual neoadjuvant chemotherapy in bladder or urethral carcinoma. He just received 2 cycles and was complicated by side effects with the hearing issues and tinnitus, and therefore chemo was stopped. Subsequently, in September 2024, patient underwent radical cystoprostatectomy and pelvic lymph node dissection and urethrectomy, so it was kind of quite extensive surgery. And pathology indicated high-grade invasive adenocarcinoma arising from prostatic urethra, and that was invading into the prostate tissue. It was staged as PT3N0, and margins were negative. Subsequent staging MRI MRI and CT was negative, and no evidence of disease. So far it's kind of no evidence of disease, and patient is on surveillance. I would briefly like to go through the prostatic urethral cancer, which is quite rare, very, very rare, ultra rare. It is just around like 3 to 4.3 per million in men, and which is quite like, I just saw a case who had like radiation-induced adenocarcinoma, but more like a small cell. So it's very, very rare, and we don't have definitive like guidance of the management and usual chemotherapy that we do for the bladder cancer. In terms of symptoms, patient, if male, then urinary obstruction, hematuria, those are the main symptoms. In female, if there's a urethral tumor, that can invade the vagina, and there could be other symptoms as well. Histology-wise, carcinoma in the prostatic urethra are primarily urethral or urothelial or transitional cell in origin, but in the penile or bulbar membranous urethra are mainly likely squamous cells. Adenocarcinoma is even rare, just in 5 to 16% of all male urethral cancer. So far, if you look into the NCCN guidelines, it just recommends cisplatin-based chemotherapy. I would briefly like to share some of my experience. The histology or genomics of the urethral tumor, right from the upper tract to the bladder to the urethra to the penile urethra, it is completely different, and it's kind of rare. Upper tract, also the urethra is rare. So I've seen all the cases. Recently, I had a patient, female, 80-year-old, had a tumor almost 8 centimeter. She was not interested in chemo, so I started immunotherapy just because there was some signature, but and also she had some history of autoimmune disease. So she was in the trial because we want to make sure that she's kind of safe to continue the treatment. Mass was not shrinking, but I did see that there's a ctDNA was going down, but there could be some a pseudo progression. So she was having symptoms. So since disease was localized, so I kind of made a decision to do EV and Pembro. EV is ADC, which we had a great discussion. And after 2 cycles, patient was seen by the urologist because she had some stone issues, and 8 centimeter mass was completely gone. So she didn't require surgery, and PET scan shows no evidence of mass, no FTG ability. So I think that was great, and it was exciting to see Dr. Sosik presentation this morning that patient didn't have to go through the surgery. So that is kind of amazing experience. We're thinking of case, but I just got a response just about a week ago. So I don't have to do chemotherapy, and also EV and Pembro is approved for the metastatic disease, but given the histology and the scientific background, I kind of discussed with the patient, and she was okay to go forward with that. Similarly, I have a case with the penile urethral squamous carcinoma, which didn't respond to the triple chemotherapy, but based on the staining like PD-L1 and MTAP loss, when I did a combined therapy with the pemetrexed and the pembrolizumab, I'm seeing some shrinkage of the tumor. So hopefully there will be further shrinkage, and patient may benefit from the combination treatment. Thank you.
So thank you, and thank you for sharing the expertise. This is an ultra-rare tumor. I think it's another great example of a tumor where it would be nice to be able to treat patients in the neoadjuvant setting, because the surgery is quite drastic for these tumors. And so let's move on and talk a little bit about the genomics of this patient. So the genomics was done by Foundation Medicine, and the specimen site was the urethra. And there's a few important things that I want to point out in the genomics. So the first thing is that this patient is microsatellite stable, so a little bit different than the microsatellite instability that would really point to immunotherapy. And the tumor mutational burden is very low. It's 1. The cutoff for tumor agnostic therapies is 10 or greater. That's the FDA cutoff. But the patient does have a lot of other alterations that I point out. So one very interesting thing is that the patient has a BRCA alterations. And BRCA alterations predisposed, they cause DNA damage repair, and they predispose to responses to agents like PARP inhibitors and to agents like platinums, because those agents in the presence of a BRCA mutation can cause synthetic lethality. But we have a very interesting contradictory issue in this patient. The way BRCA mutations predisposed to responses is because they cause homologous repair deficiency. The cell can no longer repair itself, and PARP inhibitors make that worse. They make the repair problem so bad, that's what synthetic lethality is, that the cell is no longer viable. But in this patient, surprisingly, the HRD signature is negative. There doesn't seem to be a repair problem. And so one, I think, very important question that has come up is if you have a BRCA mutation, but you don't have HRD, are you going to respond to a PARP inhibitor or platinum? Because HRD is the downstream effect of that. I don't think anybody's done a definitive study, but our experience is, and this makes scientific sense, that if you have a BRCA mutation and you don't have HRD, you're not going to respond to those drugs because it's the homologous repair deficiency that mediates the response. The patient also has a lot of other alterations that could be targeted. ERB2, ARID1A, ERB2, we talked before about ERB2 is HER2, so that might be targetable with an ADC or other drugs. Patient has EGFR amplification, that is targetable. And importantly, in the presence of EGFR amplification, there are some risks with immunotherapy. We found that a lot of patients are resistant, and some patients have an unusual syndrome of hyperprogression, where they have more rapid progression with immunotherapy in the presence of EGFR alterations. And some other alterations which are a little bit more difficult to target, RB1 and P53, which are more difficult to target as well. And in addition to doing tissue, we have this amazing technology, which now has almost become routine, but was really almost unimaginable 15 years ago, where we can look at blood and look at shed DNA into the blood and see the results of that. But sometimes the results can also be confusing, as in this case. So in this case, what we found in the blood was a GNAS alteration at a very low variant of allele fraction. And we think that that doesn't come from the tumor. It comes from something that we call CHIP, which is clonal hematopoiesis of indeterminate potential. In other words, it comes from the blood, and it's not from the tumor. The second alteration that we have is at a higher fraction, and so it's suspicious that this is real, but it doesn't correlate with what was in the tissue. So it's a KDM6A alteration, and interestingly, that alteration can be found in bladder cancer. I don't know if you want to make any comment if you've seen KDM6A in bladder cancer, but
we do see very commonly, and I think there was like a trial they are trying to kind of target that pathway, but it's still in the early phase, so it'll be very common.
So I don't know what the KDM6, so this is some of the issues that we see. We're not sure what the KDM6A is doing there. It wasn't in the tissue. And it kind of makes me wonder, maybe if this patient could have another tumor going on in the bladder. Would you do a cystoscopy on this patient?
I mean, his bladder is removed.
Well, his bladder was removed. If his bladder wasn't removed. Okay. And what we also have as part of the molecular tumor board is we have scientists that help try to put things together. And Pradeep D is one of our scientists, and he looks at all the different alterations and tries to give us some background about which drugs could possibly work, what could be put together. And he also gives us some of the domain features and why these different drugs may be helpful. So, given that the patient is not currently on therapy and is under surveillance, and the discussion in this particular patient pertains to the time of recurrence. So at this point, the patient has not recurred, but we usually do not make recommendations for patients based on the protocol in patients that are disease-free. But I'll just share with you some of the discussion that we had. So for the EGFR amplification, we discussed the possibility of an anti-EGFR antibody such as cetuximab. For the ERBB2 alteration, which is HER2, we discussed a drug that you heard a lot about earlier, which is trastuzumab deruxtecan, also known as Enhertu. And for the ARID1A and the TSC alterations, both of these can activate a pathway called the PI3 kinase mTOR pathway, and we discussed drugs like temsirolimus or everolimus that target this pathway. And for us, we would actually give the drugs together, starting at lower doses of each of the drugs, and then titrating the dose either up or down based on tolerance. And this is the sort of N of 1 approach that gives a customized combination of therapy to each patient. Now, I mentioned this before, but I think it's important to revisit it. ARID1A is a chromatin remodeling gene, and there's data, some of which we published and other people published, that it may sensitize to immune checkpoint inhibitors. And immune checkpoint inhibitors are pretty much my favorite drugs because some patients are very responsive and even cured with late-stage disease. But I want to reiterate, this patient has an EGFR alteration, and those alterations are associated with resistance to immune checkpoint inhibitors, and even to a syndrome called hyperprogression, where there's a small fraction of patients, when treated with immune checkpoint inhibitors, can have accelerated progression. So in the end, we would probably not give an immune checkpoint inhibitor to this patient. These are some of the references, and other things that we might do for this patient. We would consider monitoring for minimal residual disease with Natera. The minimal residual disease monitoring has been discussed before. And we would do additional IHC testing. We actually have a pretty extensive panel of 15 IHCs that we do at our institution. But at the very least, I think every solid tumor patient should have HER2 status by IHC, because for HER2 3+ tumors, there's an FDA-approved drug, Enhertu, which is an excellent drug, and you've heard about previously. And I think everybody should also have PD-L1 IHC status determined as well. Okay. So we then move on as part of the molecular tumor board to look at what are the clinical trials. And Dr. Vivek Sabaya will chime in about possible clinical trials that this patient may be eligible for.
Yeah, again, there are, for this patient with this extremely rare type of tumor, again, let's talk about genomically matched options. The first one that comes is PARP inhibitor. Again, I listed only one PARP inhibitor, talazoparib, but most of the PARP inhibitor studies take into account only the BRCA1/2 mutations, that they don't have an exclusion for HRD. So I think we still need to do a trial to show HRD negative, if it makes sense or not. So again, listed one of the PARP inhibitor studies, talazoparib, that takes into patients with metastatic solid tumors, regardless of histology, BRCA1/2 mutation, germline or somatic. And another option for the EGFR ERBB2 AMP is amivantamab. Amivantamab is interesting because it's approved in EGFR mutant, exon 20 mutant lung cancer. It's EGFR and c-MET bispecific antibody. And it's available both as IV and sub-Q. And there are clinical trials that take into patients with EGFR alterations and amplification. So again, there was another interesting genomic biomarker there, SMARCA4 loss. And SMARCA4 deficient tumors, again, there is no approved therapy for this, but this is an emerging biomarker. So there are several clinical trials that that need SMARCA4 loss of function mutation as one of the eligibility criteria for them. Again, SMARCA4 loss is being increasingly targeted by new modalities, specifically SMARCA2 degraders, immune checkpoint inhibitor combos. Again, another reason why immune checkpoint inhibitor makes sense here. EZH2 strategies in the SNF deficient tumors. One thing that pops up is the prelude SMARCA2 degrader, phase 1 dose escalation, and phase 2 for SMARC-A loss cohorts. And there is a Lilly SMARCA2 BRIM inhibitor as well, also taking into any tumor that have the SMARCA4 deficient tumors. This is seen in lung cancer and many cancers, although 1 to 2% across cancers. And I think if we get a good drug, this could be a tissue agnostic target as well. Again, immunotherapy combinations for SMARCA4 or SMARCB1 deficient tumors. There are tiragolumab plus atezolizumab study ongoing, EZH2 plus immune checkpoint in INI1 gene SMARCA4 context. Again, there are several of these clinical trials, EZH2 and EED inhibitors going on. And platform studies, right? Again, this is a rare form of GU cancer. Again, Dr. Biki Taba knows, enlightened us much more about this. Interestingly, he mentioned, I don't think so, he spoke, and he's mentioned about the EV, enfortumab. So enfortumab has now cohorts for rare GU cancers, urothelial program, urethral, urinary sites, and those are available in combination with PD-1 and PD-L1. So those could be clinical trial options for this patient as well. Beyond that, the ASCO taper has basket cohorts for BRCA2, EGFR, and other matches as well based on the biomarkers. Again, plenty of clinical trial options. Again, but the challenge with the clinical trial options, as you see, are patients, it'll be only one of the pathways, not a combination therapy as the patient would get from a molecular tumor board. But again, we prioritize clinical trials because that's why we can move the field forward. Again, with SMARCA4 loss, if the patient is eligible for a clinical trial with a SMARC2 degrader, I think that would be great. Thank you, Dr. Kajra.
Okay, thank you. So I think one of the things that I hope you can see is that we try to offer the patient lists of clinical trials, and we actually prepare lists with the NCT number and so forth. And we also try to suggest customized combinations of drugs and additional testing that we think is appropriate. But one of the really important issues that comes up is how do we dose those combinations? And we also provide dosing evidence based on our literature and our experience. But Dr. Nikunjan, who produced a lot of that literature, can speak to that.
So, as Dr. Kurzrock mentioned, in addition to coming up with personalized therapy recommendations, we also try to personalize the dosing. And there are a lot of factors that go into dosing, as you can see on the left, and there are many tools we have to optimize the dose. And a lot of these we summarized in our commentary from the European Journal of Cancer in 2023. So factors which can affect dosing and things which may require consideration of lower doses are: how frail is the patient? Do they have other medical issues? Are they on other medications that may interact with the drugs we're recommending? Do they have impaired kidney function or liver function? Older age can also affect it. Different genders can tolerate therapies differently, and patients of different races may have different tolerance. So those factors go into what we consider for dosing. And then we have a number of tools which can help us optimize the dose, which you can see on the right. So phase 1 studies provide information about tolerable doses. We can also look at drug levels through therapeutic drug monitoring. We can discuss with our pharmacy colleagues regarding drug-drug interactions between what medications the patient's on and the therapies we're recommending. We can look at genomic differences in metabolism between different patients and see if one patient has something that may require dose reduction. There are more advanced methods such as model-informed precision dosing, which can help us look into dosing combinations. And then, as we've mentioned several times, we utilize an N-of-1 intrapatient dose escalation strategy where we start at lower doses and then increase the dose within a single patient to titrate to continued tolerance along with maximizing efficacy. So on the next slide, dosing really shouldn't be a one-size-fits-all strategy. So we have the question, should these two patients receive the same dose? So even for standard of care combinations that we've been given for years in the clinic, if the patient on the left walks into clinic, you're probably going to give them a full dose of the drug. If the one on the right comes in, older, frail, in a wheelchair, you're going to dose reduce from the get-go, even from a well-established combination. So should these two receive the same dose? Probably not. Next slide. So in trying to figure out how to dose the novel combinations, which we gave in the iPredict study and the current TRACK study, we looked at the literature and reviewed data from almost 100,000 patients on clinical trials of combination therapy. And this data is summarized in the 5 publications shown below. And what we saw was that unlike with cytotoxic agents, with targeted therapies, biologics, and immunotherapy agents, more is not necessarily better. And if you're giving drugs in combination, if you have a lot of toxicity, more is actually worse. So what we do is start with lower doses of the drug, usually 50% of the single agent dose for each drug in the combination, and then modify it to tolerance, so the intrapatient dose escalation. Certain drugs will combine well with excellent tolerance. Antibodies, as an example, many can be given at higher than the 50% starting dose, others less so. So drugs such as PARP inhibitors, cytotoxic chemotherapy, or other drugs such as mTOR inhibitors, you may need to start at a little lower dose when given in combination. This thought that we're approving a lot more targeted biologic and immunotherapy agents has come to the attention of the FDA, and they're actually trying to reform dose optimization in oncology drug development through Project Optimus. And the emphasis there is to maximize efficacy, safety, and tolerability, understanding that more is not necessarily better.
Thank you. I want to respectfully acknowledge Catherine Skifos, who's a longstanding MTB member in genetic cancer, is currently on maternity leave. She seems to have a child every time we have a meeting, but I think she came last time pregnant. But we are having Hedel Big, substitute, who's a qualified, certified genetic counselor. And so we really try to do everything for these patients, like all aspects. And I think a lot of people ignore the germline, and we believe that that can be very important to patients. So Hedel, do you want to go on?
Yes. Thank you, Dr. Kurzrock. So when we think about germline implication, when we look at a tumor-only NGS analysis, there are several points that we consider when we evaluate a somatic report. One of the major things we look at is variant allele frequency, and if that hovers around 50%, that's when we start thinking perhaps there could be germline implication. The real range can range based on many different factors, including tumor purity, as well as other factors. And then we also look at, does a mutation match the tumor type that we would expect for that particular syndrome? Or is it very discordant and does not match and perhaps could be incidental? So examples of this could be a TP53 mutation in a patient that has a high VAF for this particular gene and has a childhood sarcoma, as that is indicative of Li-Fraumeni syndrome. So that's very concordant and matches the phenotype. Or on the flip side, you could have a BRCA1 mutation with a high VAF in a patient with esophageal cancer, which doesn't typically go in line with that particular syndrome. So we really do try to think critically about the phenotype of these syndromic conditions. So in this particular patient, this patient had prostatic urethral cancer, and prostate adenocarcinoma has been associated and established with BRCA2 mutations in terms of that phenotypic spectrum, but not so much with the urethral cancers. But when we looked at the VAF for this particular BRCA2 loss of exon 21, it was greater than 50% in the setting of a high tumor purity. So we felt that it was sufficiently warranted for us to recommend germline testing in this particular patient. Thank you.
Okay, thank you. I will open it up for questions, and I also have some questions for the panel, but if there are any questions, we're happy to address them. And if you can all, I know some of you, but if you can introduce yourself.
Rodrigo Toledo from Barcelona, Baudebron. My question is about exactly the mutation allele frequency. If in your protocol you consider VAF as an important part, if there is any way you can also access clonality, because perhaps a clonal mutation would be a better target. And yeah, so how you process all of this information, and congratulations, this is beautiful and it's amazing, very comprehensive.
So I'll give you my take on it, and the other panelists, if they have comments. So this is a really important question. So we see variant allele frequencies anywhere from 1% to, very high percentages. And a question that always comes up is an alteration that is at 1% and another alteration is at 30%. Isn't the 30% alteration more important than the 1%? Which kind of makes sense from a scientific point of view. We actually tried to look at it on our iPredict trial, the initial publication in Nature Medicine, and we could not find a correlation with outcome based on variant allele fraction. But, and this is a really important but, the statistician told us that we probably didn't have enough outliers, outliers being people with very high VAFs or people with certain mutations with very low VAFs that were either treated or not treated to be certain of the conclusion that it wasn't related. And that's why we never actually published those results. So the answer is, I think it's a really good question, and it's one that we just don't know the answer to. Yeah.
Thank you. Thank you.
This was a really fantastic. Such a great way to do.
Can we get you a microphone?
Yeah.
Hi, I'm Sarah Hesse. Thank you again for a fantastic talk and for really doing this level of detailed analysis on patients. I think it's so valuable. One of my questions was around at the beginning. I think you kind of did hint at this story, but I'm curious, with a BRCA mutated patient who's also HRD negative, that would be, I guess, in my experience, fairly uncommon. And I was wondering at the beginning if that might be kind of an anecdotal BRCA mutation. The BRCA mutation isn't actually related to the cancer in some way. But then at the end, I think maybe you were suggesting that it could actually be a somatic BRCA mutation. So I'm curious if that's the kind of thing you ultimately would try to track down for this particular case and how that could potentially either impact care or family genetic counseling.
I have comments, but I don't know. Does anybody else have any comments they want to make about that?
I mean, I think the germline testing would potentially help, isolate at least the familial aspect of it. It's possible that this is not germline, or if it is germline, it's an incidental finding and not necessarily related to the cancer of interest.
And then if we get the germline testing, right, we should get the whole BRCA gene, BRCA1-2 gene germline tested, not just hotspot BUSs, which might miss it. So again, these are unknown knowns, or unknown knowns here.
You're quoting Rumsfeld. So I'm going to add to that. So we've started doing HRD on all our patients. And we've been surprised how much discrepancy there is. Most BRCAs do cause HRD, but there is definitely a subset that are not associated with HRD. Some of them are revertants. Revertants have been known for a long time. And for those of you who are not sure what a revertant is, it's a really fascinating, to me, phenomena. The tumor tries to escape therapy. And revertance, to me, is like a very clever way for the tumor to escape therapy. So you give PARP inhibitors, which kill tumors that are BRCA positive and cause DNA repair deficiency. And what the tumor does is it mutates to turn the BRCA back normal through a series of mutations. So I think that whoever discovered that was very clever. And so some of these are revertants. Other are what we call hypomorphic BRCA mutations, and they don't cause HRD. And then there's the opposite phenomena that we're seeing. Patients that have no DNA repair gene abnormalities that we know about, but they have HRD. Now, anecdotally, we feel that patients respond based on HRD, not based on the gene abnormality. But I think somebody needs to do a real study. So that's my clinical experience, but somebody needs to actually look at it in a broader way.
Yeah. And on top of that, this patient got platinum therapy. Generally, in my clinic, what I do is that if they have some like a HRR gene mutation and patient receives some kind of neoadjuvant cisplatin and I have surgery, I tend to ask my pathologist if there's a treatment response or not. And certainly if the platinum is working, then there will be excellent response. Hopefully because the HRR gene mutation, generally they are sensitive to the platinum-based therapy. And as Dr. Kozak elucidated that there will be reversal mutation if we kind of stress through those platinum-based treatment or PARP inhibitors. So in this patient, we don't have access to the pathology, how they can be read, but most of the time for any GU malignancies, they undergo surgery. If I give some treatment, I definitely ask pathologists if there's any treatment response seen or not. If I'm interested in any gene that we can use vulnerability in a situation like this.
Are there other questions? Yes.
Hello? Hello?
Yeah.
Okay. There you go. Jeff Kramer. We have a chondrosarcoma tumor board, and I would love to compare notes in terms of the logistics and implementation of what you're doing, and probably we could learn from each other. But specifically, I'm wondering if you, beyond systemic medications and systemic treatment, do you consider other interventions, including like proton radiation or surgical, interventions? Do you consider that in your deliberations?
The answer is absolutely yes. We consider standard of care and surgery and radiation. So the idea is to consider everything for patients. Many of the patients that come to us have already had standard of care. We would actually prefer to get them a little bit earlier, but this is an example of a patient that has had standard of care. But the short answer to your question is, yes, we consider all modes of therapy. And I don't know, Dr. Thapa, if you want to.
Yeah, I can comment on that. I do very well use those other modalities for sure. And I certainly use like tumor agnostic circulating tumor DNA as well as tumor informed ctDNA and see where the tumor levels are. If responding well in the scan, but if there's a residual disease, Certainly, I asked my radiation oncology colleague to do the high dose radiation, and I've seen an excellent response in a patient if there is some residual disease left. I have few patients who had a bladder cancer, and they're responding well, but molecularly there was some level of DNAs that was emerging, and I contacted my radiology colleague, and they kind of radiated it, and which is like not standard practice, honestly speaking. And patient is MRD, scan looks fantastic, and there's no residual disease, and also like ctDNA is negative. And I'm able to de-escalate the treatment for metastatic disease so that he doesn't get any toxicity. So not only in the like the bladder, but in the prostate, in testicular, and every cancer, we can certainly do that.
So, and this is one of the reasons that we incorporate experts like Dr. Thapa, who are disease experts, along with the molecular expertise as well. Other questions? Yeah.
This was awesome. Thank you. My question is, a lot of the new agents, especially in the pipeline, if you think about ADCs and bispecifics and CAR-Ts and things like that, fundamentally target wild-type proteins, right? And you guys have done an awesome job showing that, like, kind of taking into account the DNA alterations here. How do you think we look into more whether there is overexpression or outlier status on some of these wild-type proteins? Do you think there's a role for RNA-seq? Do you think we just keep adding IHC markers? How do you guys think about that in the future?
So I'll start, and then I'll let other people answer. So at our institution, we have a really excellent molecular pathologist, Dr. Juan Felix, and he has created a 16 panel IHC, where we have 16 IHCs that we do on every patient that comes into the precision medicine clinic. And it's actually available for any patient that comes into the Medical College of Wisconsin. We also order RNA, which many of the commercial vendors will do, and RNA can be enormously helpful in our experience. Some undruggable fusions turn out to be druggable by looking at the RNA expression, because some of them, these fusions, especially in sarcomas, serve as transcription factors, and you can look at what is upregulated and what is downregulated, and we have examples of some very nice responses. So we definitely try to look at IHCs and other modalities in that way. I don't know, did you want to comment?
Yeah, absolutely. I think, the genomic cat is out of the bag because of the wide variety of commercial companies offering that. But beyond that, I think right now, more and more RNA-seq is being incorporated in some of the commercial vendors as well. So again, RNA-seq can be the first pass. We'll know which we need to test for IHC. Because, we have, again, I have one of my fellows called 875 ADCs in clinical trials. 875. Again, this is the era of ADCs. 875 different ADCs, 300 for breast cancer alone. And each of those have specific antigens. I think 20 or 30 of them are for HER2, 17 of them for Nectin-4. Again, but we need to identify those patients. Again, to identify those patients, we need to go back to do IHC testing. So we can't guess. So the RNA-seq, multiplex RNA-seq can be the first pass. And based on that, we can specifically test for those specific biomarkers for those IHC-based panels. Again, it's a challenge across many, many institutions. Again, in our institutions, it's a huge challenge because we have like a lot, like at least 100 ADC studies going on. And for each one of those ADCs for pre-screening, we need to send 10 slides. And every time it goes to the company that does the testing, if it's negative, that's it. That tissue piece is gone. So again, that's a challenge across the system. And if someone has a better solution for that, I think that is welcome. Please think about a creative solution, AI-based model screening or something, so that it becomes easy for the front-end clinician to screen for these patients.
So one thing that we've done, which we did at MD Anderson, we tried to pre-screen the genomics at MD Anderson, even when the company wasn't doing genomics. So we're pre-screening the IHCs. And IHCs cost almost nothing to do. They're amazingly inexpensive, and so the fact that we have 16 IHCs, it doesn't sound like a big deal, but I would venture to say, and you can contradict me if you, that nobody else in the world has 16 IHCs that they do on every tumor. I would venture, and it's such a simple thing to do, and yet I don't think any other institution anywhere has implemented it. And so I think that we need to be thinking more innovatively, and that doesn't necessarily mean expensive tests. Some of the tests can be pretty inexpensive as well. Other questions? Yeah. Yes, Dr. Jim.
Yeah, I have a very sort of coming back to the case kind of question, although it might be that this is a more general question as well. I thought it was noteworthy that the tumor panel and the liquid biopsy were very disparate in their results. That's the observation. The question is, what do you make of that? And then also, considering that in this case, the patient really didn't have any evidence of disease, how do you factor the presence of cell-free DNA into the decision-making about what to do with the patient in terms of treatment?
Okay, so I'll start and then I'll ask the panelists too. So the first thing is liquid biopsy, which is blood. At the beginning, when we started doing it, which was just probably around, I guess, 2016, it became available, maybe 2017, probably 2016. We noted that there was a lot of differences between the tissue and the liquid. Not to the extent of this patient where they're totally different, but with most patients, there's overlap and then there's differences. And at the beginning, what people said was, well, the blood is inaccurate. But that didn't turn out to be true. And also, I think that's a little bit of a bias, because if we had blood first, people would have said the tissue was inaccurate. So it turns out you're measuring different things. In the tissue, you're measuring a little piece of tissue and what's in that piece of tissue. In the blood, you're measuring shed DNA from really maybe a lot of metastatic sources. Like if you biopsy the liver, patient may have lung metastases or other metastases. And so you're really measuring shed DNA from different sites. On the other hand, the blood, it's very small amounts of DNA, and it's prone to missing alterations, which you might not miss in the tissue. So the way I think of it is you need to look at both together and make a decision on that point. But in this patient that is cleared of disease, that is where it's the hardest to find anything in the blood. And the blood can also be confounded by CHIP, which is clonal hematopoiesis of indeterminate potential, which means abnormalities that come from the bloodstream. They're like precursors to leukemic disorders. They're very common, these abnormalities, in older people. And so I think the GNAS abnormality was a classic CHIP abnormality. The KDM6, I don't know what it's doing there. And again, it's bladder, and maybe the other panelists can take a venture as to what that KDM6 is doing there.
Do we know how long was the duration between the surgery and the blood draw? Because many times post-surgery, there is filling of all this, there was, bladder removal, and a normal bladder can have these mutations as well. Yeah. Right? Normal bladder, urethral, can have these mutations as well. So if there was instrumentation, these could, start floating. I think that was why the MRD, the Natera MRD post thing recommendation was brilliant. I think that will offer a baseline for this post-op patient. Maybe another recommendation could be draw a liquid biopsy if post-surgery, maybe 3 or 4 months post-surgery, because then you would remove that, post-surgery, what's going on in that in the microenvironment and the tumor milieu.
Yeah, I agree with Dr. Subbaiah. I can see that heterogeneity in the tumor shedding in the GU malignancies. This urethral adenocarcinoma and bladder are very good tumor DNA shredder. So we have good experience of getting this tumor agnostic as well as tumor MRD very well in bladder, and Signata is able to detect a lot of those DNAs even after like scan is negative. But there are RCC and prostate that doesn't shred much if it is very confined, and even the RCC is the least shredder until there's a different phenotype. But I would like to share a few, like I think that ctDNA has a much bigger role as a complementary test. I had a patient who was referred to me as a renal mass, and pathologists, everybody says that this is poorly differentiated, but this is coming from the RCC. But ctDNA kind of figure out the RW1 fusion, and it was like myoepithelial, very rare kind of tumor in the young patient. In the tissue NGS also, they didn't report the fusion. I have to call back the testing company to confirm that, and they have to change the report. So diagnosis kind of changed, and management was changed after that. Similarly, in also like in many instances where I'm getting experience that there's nothing in the scan, but I'm seeing those ctDNA coming up, and there are mutation that is kind of emerging, and that is giving us a good lead time and also do the intervention right on the time. I think in this patient, if tumor is coming back, even microscopically, we'll be able to detect pretty good because of the biology and the nature of the tumor shedding. Certainly, repeat would be helpful if those are stable or not. I do see a lot of shift, which is like 10% or something. I had one patient who has a prostate cancer, but I was able to pick up like a mutation for melanoma because patient has a history of melanoma, and patient underwent surgery for the like a transient this thing. So it has major role, but it depends on what context.
I have a question for you, Dr. Sapp. Do you think there's any chance that they missed a bladder cancer in the cystectomy, or they would have looked at that carefully enough? They took out the bladder, but could there have been a bladder cancer someplace hidden in that bladder that they missed that would explain the KDM6?
It could be highly possible. Like tumor can come from all the way up from the urethra, and kind of they fall and they form like this in the bladder as well, and that could be highly possible. But we don't have the data of what exactly in the cystoscopy because initially they were not able to go because everything was kind of blocked. But after like tumor resection, if they can comment on the bladder, that would be helpful. But we don't have that data.
Yes. Can you speak a little louder? Yeah.
Yeah, 3 questions, but I only asked 2. Jeff Finstrom from Eli Lilly. The first one, I guess, is around piloting any generative AI tools, either for identifying novel insights or even communicating the results back to the patients. Supposedly, ChatGPT of the likes are more empathetic than us providers. And then the second question is, I'm intrigued by the personalized dosing recommendations, and do you find value in doing bona fide kind of pharmacogenomic profiling, either the cytochrome P450s or others? Maybe I missed that.
Okay, well, let's start with the AI question. And Dr. Sabaya, you want to comment on that?
Absolutely. I think the protocol is written in such a way that is said, but I think that is a great idea for future protocol or an amendment of the protocol. I think, right when the protocol was designed, ChatGPT did not exist. And right now we have ChatGPT, we have Claude, we have the challenge with ChatGPT and Claude I've seen is a lot of hallucinations in medicine. Again, in medicine, open evidence is much better, but it won't spit up these clinical trials for this patient. So I'd be cautious with using, again, we need a purpose-built ChatGPT or Claude or one of the Gemini tools for clinical trial and genomic matching. Again, we don't have that yet for prime time, real time. Again, there are working in the back end, and Trial GPT is also an NCA project that's been worked in the back end, but it's not ready for prime time. Again, we need Dr. Kurzrock, Dr. Nikanjam, Dr. Biki Tapa right in front, and it's not ready for prime time. But again, it's a great idea to include AI, generative to build a pilot model for this program. Model for a future study could be human tumor board plus AI assisted human tumor board, not versus.
Thank you. And Dr. Nakanjo, you want to comment on the dose?
Can you ask the dosing question again?
are you finding any value in implementing bona fide kind of pharmacogenomic profiling for like the cytochrome P450?
We generally don't have pharmacogenomic profiling for the patients coming in, but I think it would be helpful. Many of the drugs can be affected by this and other factors, so we don't have that implemented now. Generally, the patients, they get the foundation liquid and tissue, and they don't have, I don't think Foundation offers pharmacogenomics currently. Some other companies were offering it for a time, but if we get that information, that would be helpful to add in.
And I think certain institutions, that Tapa can perhaps comment, they do DYPD testing on all patients, right? So you want to comment on that?
Yeah, I think interestingly, Guardian 360 started giving that pharmacogenomic component, and I like that because I tend to see what the drug metabolism for particular patients. So I do see that CYP3, DYP, everything coming up, which is like they are kind of expanding their test. And interestingly, I'm able to reduce doses in some, even for the ADC, so I should not give higher dose with the increased toxicity. But I think that makes much more sense. But pharmacogenomics would be great helpful to optimize or personalize the dose as well.
Because an institution in Boston is in national news because of that. Now they are mandated because of one suit or something. I think they mandated DYPD testing in every patient.
That was for 5FU or Reno-TQ?
Every patient. They are doing DYPD testing.
We're seeing that even for the novel antibody drug conjugates, right?
Yeah.
Some of the moieties that are attached to these ADCs.
Yeah, no, absolutely. Another thing that's also adds another layer is HLA. HLA testing, right? HLA testing also is another important addition that could be added on, and that's also emerging that could impact biomarkers, immunotherapy response, and also response to pharmacologically targeted therapies. But it's still early. But think about that. I think again, I've been to many molecular tumor boards. This is one of the highest quality molecular tumor boards you can get. This is ultimate customized NF1 personalized medicine at its finest. Again, we can make it better, and we need to make it better. But AI and all these layers can be added on. But this is I believe that this is one of the best MTBs across many institutions.
And maybe just really quickly, are you making any recommendations around CHIP? I mean, you mentioned it a couple of times, and because of the age-associated clonal hematopoiesis, there are CHIP clinics throughout the United States, right? And so it seems like there are opportunities to address CHIP as part of your reports.
Yeah, so CHIP is part of the Foundation Medicine report now. And so I think that that's a really important incorporation. And I'm sure that they have their algorithms that have been validated before they say something is probably CHIP. With the pharmacogenomics, we've looked into it in our clinic. We're actually looking into it again. It's not as easy to get pharmacogenomics as a routine basis as it is the other NGS tests. And I think that that's really a shame because, it can tell you how to modify doses. We modify doses almost automatically for all our patients. We often start at half doses, even for routine therapies that are because we've just found that patients do better. And then we escalate the dose to full dose if they are tolerating it. But I think your point about pharmacogenomics is well taken, and I would hope that some of the commercial vendors that we commonly use would incorporate these pharmacogenomics into their products as a routine part of the product.
I can comment on CHIP.
What?
CHIP. I could comment on the CHIP. I think CHIP is an interesting one, which we know very much about it and a lot of data, especially in the solid tumor. Especially I treat a lot of elderly patients with the prostate cancer. I'm interested to see in my patient or in general for the data because they are getting like radioligand therapy and PARP inhibitors and some of the platinum-based, whether they will be increased, if there is a higher VAF of the CHIP, then will they be increased risk of the MDS or leukemia? Those data are emerging, and those radioligand therapy is coming more like upfront treatment. So I'm very cautious about choosing a treatment, also looking at the chip as well. Whether if there's a lot of chips and very high risk chip, then should I go with the ligand therapy versus different therapies? So that's kind of my personal approach. Additionally, like in the bladder cancer, if there are like a chip high, there's a data to suggest that in a solid tumor, immunotherapy might not work because of the chip, and those are like a chip in the tumor microenvironment. Those data are emerging, but certainly I'm kind of looking into those data as well in my patient population.
Okay, well, I think our time is up, and we're right on time. And I really wanted to give a special thanks to our panelists who convene every week. And I hope that we're helpful to our patients and to your questions. Thank you.